Hi friends, this is David Dalton. I want to start by mentioning that I am not an attorney. Let me just get that point out of the way. However, considering the litigious society that we live in and the ever-increasing number of lawsuits being filed not only against EMS agencies, but also against individual providers, we owe it to our families and ourselves to be well acquainted with the laws of greatest relevance in our industry. As an EMS educator, I've spent years teaching EMTs, paramedics, firefighters, nurses, and others a simple philosophy: prevention is better than crisis management. In other words, when it comes to preparing for the worst case scenario, it's better to be proactive than reactive. Do everything you can to prevent the zombie apocalypse before it even starts. Think of it this way. When is the best time to buy a fire extinguisher? Before the fire starts. When's the best time to put on your seatbelt? Before you have an accident. If you go to play a game without knowing the rules, how do you avoid breaking them? Therefore, when is the best time to know the law? The answer is before you break it. Have you ever watched one of those movies where an airplane pilot suddenly drops dead and some poor passenger is left with no choice but to fly the plane himself? This dude can hardly fly a kite, let alone a commercial aircraft. How is he going to land without killing everyone on board? Of course, we all know how the Hollywood version of the story ends. The guy somehow manages to land the plane safely, and all 100 passengers walk away without a scratch. Unfortunately, the real-world version of this story has a very different ending. Instead of end credits, we get a long list of obituaries. My point is, some lessons are just too painful to learn through experience. And yet, when it comes to legal matters, it seems that many EMTs and paramedics have had to learn a lot of things the hard way. You may have heard someone say that there are state and federal protections that limit the number of things that an EMS provider can be sued for personally. And yeah, that's true. You see, years ago, the government enacted various immunity protections to shield first responders from being sued for making mistakes that happened on the job. So the idea was the government was concerned that if anyone could file some frivolous lawsuit against an EMT, paramedic, firefighter, or so on, that no one in their right mind would want to become a first responder. So, for the good of the public, the government, both state and federal, put these various protections in place. However, those limits have limits of their own. If you break the law on accident even, do not expect the judge to hand you a get-out-of-jail-free card just because you're a paramedic and you didn't happen to know any better about that law. There are certain things that are not covered by those immunity protections, so don't count on immunity. If you act with gross negligence, for example, or if you inadvertently infringe on someone's constitutional rights, you may find yourself completely vulnerable to litigation and sitting on the wrong side of a courtroom. And it doesn't matter that your EMT instructor never bothered to discuss special theory negligence like res ipsa loquitur or negligence per se. Did your training officer forget to explain why the legal definitions of words like reasonable or intentional can mean the difference between winning and losing a court battle? They didn't tell you? Too bad. The judge isn't going to say, "Oh, you mean you didn't know that was against the law? Well, shucks. Officer cut him loose. He didn't know any better. Case dismissed." Yeah, right. I hate to be the one to tell you this, but not knowing is a lousy defense. This is one situation where ignorance is not bliss, it's just ignorance. Because in the eyes of the law, you should have known. Today, as we examine the issue of involuntary transport and patient restraint, we'll spend quite a bit of time discussing two of the biggest legal pitfalls facing EMS providers: gross negligence suits and civil rights violations. Neither of these are eligible for immunity. But first, let's put your legal knowledge to the test. Without consulting Google, can you tell me about the Fourth Amendment? How much can you tell me about the 14th Amendment? And what about 42 U.S.C. Section 9501? I'll give you a hint. It's also referred to as the Mental Health Patient's Bill of Rights. Surely you know that one, right? Oh, and speaking of the 14th Amendment, are you aware of how the landmark case of Terry versus Ohio helped in the interpretation of the 14th Amendment and why that's relevant for us? If those things are altogether unfamiliar for you, don't sweat it. You are in good company. However, the risks are just too great to ignore. So I want to take a moment throughout this session, and I hope that you find it beneficial. But I'm hoping by the time we're wrapped up today that you are much more familiar with these concepts and more, and are better equipped to protect yourselves and your coworkers from lawsuits and worse. Today we're going to contrast two legal cases. The first is the case of Brett Weiner, the young man you see on the left side of your screen. The second is the case of Kowalski versus St. Francis Hospital in New York. You're going to see some very similar components to these cases, things that they share in common. And then also, before we finish today, you're going to see some very stark differences. But let's start off with Brett. At the age of 21, Brett is a college student, an All-American athlete, but he's battling major depression. One night, his condition grows so intense that he begins hearing voices telling him to commit suicide. He's taken to a hospital, and the following morning, his nurse arranges to have him transferred to a psychiatric facility. Upon arrival of EMS, the nurse explains that although Brett has been perfectly compliant, a perfect gentleman for the ER staff, the physician still considers Brett to be a flight risk. And so EMS goes into Brett's room, they introduce themselves, they walk him out to the ambulance, and once in back, the attendant anchors Brett's wrists to the stretcher using a pair of soft restraints. He then sits down on the bench seat, and the ambulance departs on what is thus far a very classic example of an unremarkable, run-of-the-mill routine psych transfer, indistinguishable from thousands of others exactly like it. We've all run these calls many times, but the ordinary and mundane was about to change drastically. About 10 minutes into this trip, Brett asks the attendant sitting beside him, "Could you please move to the seat behind me? Because having you sit there right beside me is making me very uncomfortable." Well, not wanting to cause his patient any extra anxiety, the EMT says okay, and he steps up, moves from the bench seat to the captain's chair behind the stretcher. A few minutes later, the EMT receives an unpleasant surprise when he sees Brett is standing straight up in the back of the ambulance, free of his restraints. Quickly, the attendant grabs Brett and struggles to keep him inside the ambulance. The driver, hearing the commotion, pulls over to the shoulder of the highway and radios for help. Brett escapes and sprints across 7 lanes of traffic and just keeps on running. Now, amazingly, there happened to be an off-duty police officer nearby who catches wind of this, and he gives chase, apprehending Brett just a few moments after he escaped. The officer and Brett talk for a few minutes, and once the officer is convinced that Brett has calmed down sufficiently, he begins to escort Brett back toward the ambulance that's waiting on the shoulder of the highway. Just as they reach the road, Brett pulls away from the officer, steps into oncoming traffic, and is struck by an oncoming pickup truck. He dies there on the scene. 18 months later, a jury awards Brett's family a $1 million judgment and finds the attending EMT guilty of gross negligence. Now, we'll come back to this case and examine it in a little more detail later on. But first, I want to tell you the story of Kowalski versus St. Francis Hospital. Driven to the ER by a friend, an intoxicated man by the name of Kowalski wanted to be admitted to the hospital's detox program. Despite having a blood alcohol content that was off the charts, Kowalski is alert and somehow manages to walk without help. He's taken to a room where an ER physician visits with him for a bit and agrees to admit him to the hospital's detox program. The patient sits in the ER for about 4 hours awaiting transport to detox, and eventually he decides he's waited long enough. He removes his IV and tells the nurse that he's leaving. The nurse asks him to wait for just a few moments so that she can go and inform the doctor, and Kowalski agrees to wait. Nurse runs to find the doctor. She returns a few minutes later only to find that the patient is already gone. She rushes back to the doctor and asks if he wants her to call the police. The doctor says no, and, well, long story short, after walking away from the hospital without an escort, the patient is struck by a car less than 2 hours later and is severely injured. Well, as you can imagine, Kowalski sued the hospital. His attorney argued that because Kowalski was drunk, the doctor should have protected him from himself, because he wasn't of sound mind. Well, you can probably guess who won that lawsuit. The hospital. Yeah, that's right. The hospital won the case, because the court ruled that the physician had no right to hold Kowalski against his will. But wait a minute. How is that possible? Kowalski was intoxicated. No one disputed that fact. It was known that his blood alcohol content was high. Wouldn't that be enough reason to justify treating him as an involuntary patient? At least until he sobered up? We'll revisit these cases a bit later. But let's sum up. With Brett Weiner, you have a case where a suicidal patient escapes the ambulance and dies. An EMT is found liable and ruled to be grossly negligent. And then with Kowalski, you have a drunk patient who leaves the ER, AMA, and is struck by a car and severely injured. But the physician is exonerated of all wrongdoing, and the court says he had no authority to hold the patient against his will. Now, does this strike you as a contradiction between these two cases? We'll come back to this in a few moments. But first, here's another pop quiz. True or false this time? Let's find out if you were paying attention earlier. True or false? When an EMT or paramedic restrains or transports a patient against his will, the patient may be able to sue the ambulance service, but not the provider personally. That is false. What if medical control authorizes an involuntary transport or the use of physical or chemical restraint? Isn't it true that at that point all liability is transferred to the physician and the EMS provider is protected? Well, once again, The answer is false. Regardless of what a doctor tells you you should or should not do, if your actions are grossly negligent, if they are a gross departure from the standard of care and your patient suffers as a result, or if you violate your patient's civil rights, you could be held civilly or even criminally responsible. The Fourth Amendment of the U.S. Constitution states that people have the right to be secure in their persons as well as their effects against unreasonable searches and seizures. Now focus in on those two words I have underlined on your screen. You have the right to be secure in your person against seizure. When we transport someone to the hospital against his or her will, we are in fact making a seizure of a person. This has been affirmed in court multiple times. That puts us under the microscope of the Fourth Amendment. This is just one reason why we always need to have justifiable, reasonable cause whenever we perform an involuntary transport or place someone in restraints. And by the way, you don't even have to lay a finger on the patient to be guilty of violating his or her Fourth Amendment rights. In the case of Terry versus Ohio, the court affirmed that a seizure of a person occurs when someone, by means of physical force or by show of authority, has in some way restrained the liberty of a citizen. Now think about that. A show of authority. In other words, if a reasonable person would, when meeting with you, not feel free to walk away from that discussion at any point at which they choose, that qualifies as a seizure. Now, we often think about this more referring to law enforcement because the person standing there wearing a badge, if the individual feels like they are not free to walk away at any time, that constitutes a seizure. The same can be said, though, of EMS. Have you ever heard a police officer say these words? You can either go to the hospital with EMS or go to jail with me. You've never heard that before? Well, that's surprising. Well, if you yourself are in the habit of using those words, please stop. Don't let that phrase ever escape your mouth again. And if law enforcement officers in your area are using this phrase commonly, you need to have your administration work in tandem with theirs to try and educate the officers and put an end to it. Nothing good can come from saying those words to someone who already does not want to go to the hospital. Allow me to explain. First, let's call this what it is. It's a threat. Does the patient feel free to leave at any time he wants? No. Therefore, could this constitute a seizure? Absolutely. When someone is being difficult, refusing to let us take them to the hospital, and we say these ridiculous words for the sole purpose of coercing them into going with us voluntarily, if you can call it that, honestly, to call them voluntary is not entirely accurate. It reminds me of that scene where RoboCop says to the bad guy, "Dead or alive, you're coming with me." No matter what the dude says, his opinion, in all reality, does not count for anything. No matter what the guy says or does, he's going whether he wants to or not. There's no third option. The hospital or jail. That's the impression you're giving this patient. Even if he replies, okay, I'll go to the hospital peacefully, that's not quite the same thing as being voluntary. It's being voluntold. And legally, that puts us on thin ice. Likewise, just threatening the use of restraints is enough to qualify as false imprisonment and even assault. For example, saying to a patient, "Hey, if you don't behave, I'm going to put you in restraints." That's a bad idea if you don't actually have a justifiable reason to use restraints on a person. Don't threaten. Do or do not. Restrain or don't restrain. If you feel justified to threaten someone with the use of restraints, you probably have plenty of reason to just go ahead and restrain that person. The second reason for avoiding that infamous phrase is the small little matter of scene safety. Let me ask you this. How do you respond to ultimatums? How do you respond when someone threatens you? Do you get all warm and fuzzy inside and think, ooh, that's just all great? Or do you start to feel more like Bruce Banner does just before his skin turns green? With that in mind, throwing threats into an already volatile, emotional situation is a lot like throwing gasoline on a fire. Trust me, it's not likely to make things better, but there's a good chance it will make things a whole lot worse. Just before you get sealed up in the back of the ambulance with this guy, without all the tools and tactics that law enforcement has at their disposal, you really want to be stuck in the back of a little box on the highway with someone that you've just threatened? So what on earth do we hope to accomplish with these threats? What's the point of poking a stick into a hornet's nest unless you just really want to be stung? If the patient has done something bad enough to truly make jail his only alternative, he probably doesn't need to be in the back of your ambulance. Just a little food for thought. But let's say that you do have a valid reason for taking a patient to the hospital against his will. You're not out of the woods yet. A lawful seizure can quickly become illegal if it's carried out in an unreasonable, or what the law refers to as an extraordinary manner. To explain this, let me give you an example. Paramedics in Wyoming found themselves in hot water after forcing a suicidal patient to go to the hospital against her will. Now wait a minute, you're thinking, wait, forcing a suicidal patient to go to the hospital, that got them in trouble with the Fourth Amendment? Well, let me explain this a little further. Their decision to take her involuntarily wasn't the issue. It was the manner in which they took her, carrying her to the ambulance naked and handcuffed for all the world to see. That was a big problem, and it was ruled to be a violation of her Fourth Amendment rights. You know, I've heard medics say that we should make a habit of restraining all psych patients, just as a matter of routine, just to be on the safe side. What do you think? Does that pass the reasonability test? Absolutely not. Schizophrenics have the same rights as you and I. Just because they've been labeled a psych patient, that fact alone is not sufficient grounds for an involuntary transport. The most commonly alleged violations involving EMS are violations of the Due Process Clause of the 14th Amendment, which guarantees that the government shall not deprive any person of life, liberty, and so on without due process of law. Even when you genuinely feel like you're doing what's best for the patient, if he or she is of sound mind and you take away that person's liberty without lawful justification, it's false imprisonment, period. And like the Fourth Amendment, you don't actually have to apply physical restraints or lay hands on the person to be guilty of false imprisonment. The threat alone is enough. And while it's true that criminal charges against providers for false imprisonment and kidnapping are rare, civil suits for false imprisonment are much more common. And if that weren't reason enough to know the laws governing restraint and involuntary transport, consider this. If you restrain a competent patient without just cause, The second you make physical contact, you've just committed battery. Deprivation of a person's liberty is always a serious and risky matter. Balancing a patient's civil rights against his or her safety, not to mention the safety of everyone else, is no easy trick. But in pre-hospital medicine, the reality is that whether we realize it or not, whether we like it or not, we often walk along a fine line that divides patient care from taking custody, the latter of which is the purview of law enforcement, not EMS. And yet sometimes it's really hard to tell the difference. As I said to begin with, if we don't know the rules of the game, how do we avoid breaking them? So now that I've left you terrified of the thought of transporting an involuntary patient ever again, let's discuss some of the things that actually justify involuntary transport and the use of patient restraints. Likelihood of serious harm. Now these are the easy ones, right? Where we have a patient who is an obvious threat to themselves or others. They're suicidal or homicidal. Now, in the best situations, as far as being able to justify involuntary transport for someone that is a threat to themselves or others, the more information you have, the better. Do they demonstrate a clear intent to cause harm? Do they have a plan formulated? We talk about this with suicidal patients all the time. Do they have an elaborate plan for how they are going to kill themselves? And then do they actually have the means to pull off that plan? If they say they're planning to shoot themselves, do they have access to a gun? Now, we talk about grave disability, we're talking about a substantial risk that serious physical harm will result because of an impairment in the capacity to make decisions with respect to hospitalization and treatment. And this is evidenced by mental disorders resulting in an inability to provide for their own basic needs like food, clothing, shelter, and to provide for their own medical care, or having an inability to provide for their own mental health care. Evidence of a substantial risk may also include information about patterns of past behavior that have historically resulted in serious harm. All of that can be used to justify involuntary transport under the concept of grave disability. Let's take a look at Minnesota state statute specifically. According to Minnesota law, substantial psychiatric disorder of thought, mood, perception, orientation, or memory which grossly impairs the patient's judgment, behavior, capacity to recognize reality, or to reason or understand. And all of those things, by the way, could include not just a mental illness, but something else that diminishes their capacity, such as a stroke, a diabetic emergency, Alzheimer's, or even a traumatic brain injury. Any of those could qualify if they have impaired the person's judgment, behavior, and capacity to recognize reality or to reason and understand. And these things would be manifested by grossly disturbed behavior or faulty perceptions, and you also must be able to show that this person has a substantial likelihood of physical harm because of this mental state. In other words, the threat is imminent. This is your law in Minnesota. Now, I should state that your law also specifies that a person is not considered mentally ill if the impairment is solely due to epilepsy, developmental disability, a brief period of intoxication from alcohol or drugs, or anything else that alters the mind, but on a self-limiting basis. That doesn't qualify as mental illness under this statute. Likelihood of physical harm to self or others. Again, we're looking specifically at Minnesota law. As a result of the impairment, the patient is unable to obtain food, clothing, shelter, or medical care. Doesn't this sound familiar? The patient is likely to suffer substantial injury, illness, or psychiatric deterioration unless treatment is rendered, or in other words, they have a grave disability, or the patient has attempted or threatened to harm themselves or someone else, or if they have caused substantial property damage, in other words, their behavior is destructive. Any of those things can be used as evidence of a likelihood of physical harm to self or others. But for it to qualify under this statute, this likelihood of physical harm has to be the result of some mental impairment. And the threat to the safety of others is an overt threat.
Hey, come over here. Hey, the ambulance is over here. Come on. We're trying to get you help, bud. Go over and see the girls in the ambulance. Come on. Come on. Go over see the girls in the ambulance. They're going to get you the help. They just want to check your vitals. That's all they're going to do. Come on. That's all they're going to check your vitals. Make sure everything's okay.
What's your name? You speak English? Hey. Hey. Get ready to wake up. Or you want me to have the pleasure? Pop it. Breathe that in.
You don't want it up your nose and talk to me. Stop acting stupid. You're a grown man. Tell me. Open your mouth and talk to me.
Alright, so check this out. Can you please tell us your name so you can take this out your nose? I know it stinks. We know it stinks. Come on, partner.
It's just your name.
If it's an act, it's a pretty good act.
Yeah.
Because I see the same thing when I see a variety of drugs being used.
Yeah.
Now, if you're taking something, we're not here to judge you.
What you been
You want to
taking?
get treatment. If you're taking anything, we're going to get treatment for it.
What you been taking?
Well, supposedly he was naked on top of the cab of a tractor.
I just want to go ahead to the substation and go to sleep. So if you tell me your name, we'll let you go so I can go back to bed.
Rodrigo.
Do you want to go home? Or do you want to go to the hospital? Or do you want to go to jail?
Okay, if you don't want to go to the hospital, you can go with me.
Well, those are your two
Then
choices.
come on, I'm going to give you a ride. You don't want to go to the hospital with you, so let's go. His vitals are good, ladies?
Yes.
All right.
Have a nice day.
I ain't giving you a ride to jail, because if I was going to give you a ride to jail, you'd be in handcuffs. You're not in handcuffs. You're not under arrest. I'll figure out where you live. Give you a ride to a safe environment. That's all I want. I want to make sure you're all right.
That brings us to what is perhaps the most pivotal point that I'm going to make in today's presentation. Mental capacity. You've heard me use that term a few times, but now I want to explain it in a little bit more detail and also give you some tips for how to evaluate it in your patients. The sad fact is there's not really a good, standardized, proven valid tool for assessing mental capacity in an environment outside of the hospital. And what's worse is that most EMTs and paramedics are taught to ask very simplistic, routine questions regarding orientation, such as, is the patient awake, alert, and oriented to person, place, time, and event? Unfortunately, those questions are not sufficient in evaluating the mental status of your patient and determining whether or not they have the capacity to make an informed refusal of care. Now, there are numerous resources on this and suggestions for other means of assessing patients' capacity. I have those up on my website, and I'm adding more all the time. If you go to emsrestraint.com and click on the free resources tab, it'll take you to my Google Drive where you can download any of those documents, any of those tools and resources at absolutely no charge. I'm not trying to sell you anything there. It's there for your use, and I mention it because we just don't have enough time to go into that in depth today. In any case, I do want to give you some very general tips for testing patients for their mental capacity. The first is, does the patient fully understand the relevant information? For example, you could ask the patient to paraphrase what you've just told them. Not to regurgitate word for word what you just said, but to paraphrase it in their own words. And then secondly, does the patient have the ability to process that information? So you could, to assess their ability to process information in general, you could ask them about a hypothetical situation based on what a rational person would do in that circumstance. A patient with normal capacity should be able to demonstrate that they understand the information and decision-making processes. Then third, does the patient have the ability to make a choice? And I mention this because if the patient is asked multiple times to make a decision about something, the same thing, but multiple times they change their response to that question within a short period of time, so you ask the same question, you're getting a different answer every time, that could suggest that their capacity is impaired. Their thoughts are disorganized. And then lastly, can the patient put all of these things together and appreciate the situation and the potential consequences? They should be able to communicate that they understand the seriousness of the potential outcome of refusing treatment and transport. So that's mental capacity, but there's also the question of legal capacity. So, for example, legal capacity would mean that you would be asking the question, does the patient have the legal right to refuse care? Are they, for example, an underage minor, as defined by your state? Are they emancipated if they're a minor? Are they married as a minor? Do they have children of their own? And then if they are not a minor, then what about adults who are in police custody? Have they been arrested? Once more, let's focus in on the Minnesota Commitment Act of 1982. Commitment is a long-term situation that is actually determined through a legal process. It involves the court. That's not something that we deal with. Then you have a step down, which is called an emergency hold, which in Minnesota is a 72-hour period where the person is kept in a medical facility to be monitored and until such time as they are safe to release, or until legal proceedings could take place to initiate the commitment process. And then you step down from that, and we have what's called an emergency transport hold. This is more in line with EMS. It is something that authorizes us to transport a person to a medical facility for further evaluation by a physician. who can authorize this emergency transport hold I just mentioned? Minnesota allows for the transport hold to be ordered only by a licensed peace officer or health officer. Now, a peace officer, that's pretty easy to identify. Basically, we're talking about law enforcement. But when I first began to research Minnesota's laws and I saw the title health officer, I thought to myself, what on earth is that? You see, being from Missouri, I was entirely unfamiliar with that term. Right there, we have an example of state-to-state variability in law. We don't use that designation in Missouri. Anyway, after reading through Minnesota law, I learned that health officers include persons like medical doctors, mental health professionals such as psychologists and social workers, certain RNs or advanced practice RNs, and a few other professionals. But what was noticeably absent from the list were EMTs and paramedics. They are not considered health officers. So, under the law, while EMS is legally able to transport an involuntary patient, evidently you have to do so under the authority of either law enforcement or one of the healthcare professionals that fall under the title of health officer. This is markedly different from what we have in Missouri. We have a law that was passed just within the past couple of years that now permits EMTs and paramedics to transport involuntary patients at their own discretion by their own authority and without having to involve a third party. But getting back to Minnesota, what role does an EMT or paramedic play in this entire process? Well, if you follow the letter of the law, once you determine that your patient lacks mental capacity and is in need of medical care but is refusing treatment and transport, you would need to obtain an emergency transport hold order from a law enforcement officer or from medical control. Only then can you legally transport a patient against his or her will. Now, I don't know how things are up in there in Minnesota in daily practice, but I do know that in Missouri, before the law that I previously mentioned was put into place, we were transporting people involuntarily all the time. But there was no actual law that mentioned EMTs and paramedics that would protect us if it was brought up in court. That's why this new law was pushed into legislation. In any case, in Minnesota, I don't know if there are situations where people are not necessarily following the law in black and white, but there's like an unspoken exception. I honestly, I don't know. But if you're following the letter of the law, you have to do emergency transport holds under the authority of law enforcement or a health officer. Obviously, there is some fine print. There are some caveats to be aware of here. So ultimately, it's up to you to educate yourself on the ins and outs of the laws in your state. I cannot overemphasize just how important that is. Well, we have certainly covered a lot of ground in a very short span of time today. And I also realized that the last section of material was pretty dry, so I hope you're still conscious out there. If not, perhaps this will help. I want to take a moment now to go back and take a second look at our two case examples. First, we had the case of Brett Weiner and his wrongful death suit after escaping from an ambulance and being struck by a vehicle. And then we had the case of Kowalski, wherein an intoxicated man left the ER, AMA, and was later struck by a car. I want to give you an opportunity to apply what you've learned so far. Let's start with Kowalski. In the Kowalski case, the question the Court of Appeals had to answer was whether the physician's duty to his patient included prohibiting him from leaving the hospital. Now, New York case law dictated that a physician could only exercise this kind of power when a patient is truly at risk of imminent harm. Does that sound familiar? It should, because we talked about this very sort of thing. But my question to you is, was the threat of harm in the Kowalski case truly imminent? Now, sure, it was a possibility. Generally speaking, being drunk can increase anyone's odds of getting injured, whether it be in a drunk driving accident, a fall, or perhaps accidentally stumbling into oncoming traffic. But a potential threat is not the same thing as an imminent threat. The word imminent implies that more likely than not, this is going to happen. It's not that something bad could happen, it's that it probably will. That is the word imminent. So, intoxication alone isn't sufficient justification for taking away a person's liberty. Let me give you a little example here. Maybe this will make it more tangible. If you happen to have one too many adult beverages one night at your home, and you found yourself hugging the toilet later that night, and then all of a sudden you hear a knocking at your front door, and hear a voice say, "EMS, let us in." And someone there tells you that you have to go to the hospital whether you like it or not because you're drunk. What would your reaction to that be? Is being drunk, all by itself, is that a medical emergency? So, getting back to this story, and I just want you to give that some more thought later on. But intoxication alone, without evidence of a diminished mental capacity, is not sufficient justification to take away someone's liberty. But what else can we say about Kowalski? Let's examine his mental capacity for what it was. He was not delusional. He wasn't talking to pink elephants or taking orders from his pet chihuahua. He wasn't suicidal. He wasn't homicidal. There was no evidence to suggest that he met the criteria for having a grave disability. He was able to walk by himself and carry on a conversation. The doctor's assessment revealed nothing that would suggest Kowalski had a coexisting illness or injury. And by his own admission, Kowalski admitted he was simply drunk, nothing more. In short, the threat of imminent harm to himself or others simply does not apply in this case. But what about legal capacity? Was Kowalski under arrest or otherwise in police custody? No. Was he a minor? No. Did anyone else have legal authority to make decisions on his behalf? Not that we're aware of. Based on the totality of the circumstances, the doctor, not to mention the jury in this case, felt that despite having an unquestionably high blood alcohol level, Kowalski was nevertheless still in control of his faculties, and that's what mattered. In other words, he had the mental, legal, and situational capacity to make his own choices, and as such, he had every right to refuse care and walk out of that hospital. And if he had the right to refuse, then the doctor had no authority to hold him against his will, and therefore the doctor could not be held liable for what happened to Kowalski after he left the hospital. Case closed. Right now, some of you watching this presentation are still very uncomfortable at the thought of letting a patient like Kowalski refuse treatment and transport. However, if you keep a few legal precepts at the forefront of your mind, you should have an easier time when facing decisions like these. The Kowalski case underscores the fact that, until proven otherwise, everyone is presumed to have capacity and, by extension, the right to make their own choices regarding their medical care. On every patient encounter, that presumption has to be our starting point. Our laws value and protect personal autonomy, the right to choose for yourself. Being drunk by itself is not a life-threatening emergency, and being intoxicated doesn't necessarily cause a loss of mental capacity. And by the way, does every patient with schizophrenia or bipolar disorder automatically lack mental capacity to make informed decisions? No. Remember, the label is irrelevant. It's your assessment of the patient's capacity in the here and now that counts. Has the patient been hallucinating today? Is he hearing voices telling him to harm someone or himself? Is he off his meds and so gravely disabled that he needs to be hospitalized? Forget the label of psych patient. Assess your patient in the here and now. And here's one more critical thinking question for you. Can a person who overdosed on heroin, who received Narcan and woke up and is now in possession of his faculties, is able to answer all questions appropriately and demonstrates that they have mental capacity, once you've woken them with Narcan and they're of sound mind, does that patient have the right to refuse transport to the hospital? Now, we're not going to have time to go into this. You're going to have to consult your own local law and local protocols. However, if you follow the letter of the law, the Constitution, the person has mental capacity. At that time, they can refuse treatment and transport. Whether we agree with it or not, that's how the law is written. But again, consult your own state laws to make sure. An attorney who also happens to be a nurse did an excellent job summarizing the lessons learned in the Kowalski case. Providers must respect the legal rights of all patients, and that includes those who present with mental health or intoxication issues. We can't take a paternalistic approach and hold someone against their will because that's what we think is best for them. We assess them to determine if there is an immediate risk of injury to themselves or others, and the decision to involuntarily detain them is based upon that determination alone. If the determination is that the patient does not pose an immediate risk, we explain the risks, benefits, and alternatives of leaving against our advice, and we document that conversation. But patients have the right to make their own decisions about staying or leaving. The laws regarding patient rights reflect a culture that values autonomy and respect for a patient's ability to make decisions regarding their own health care. Now, I want to underscore something here. The decision that the patient makes doesn't have to be a smart one. It just needs to be an informed one. If you have a patient, for example, that is complaining of chest pain, but they refuse to go to the hospital because they're afraid of what might happen to their dog, hey, if the person is of sound mind, that may be a stupid choice, but he has the capacity to make dumb decisions. We have to respect that. Does the patient have capacity? That is the one and only question here that matters. All of the other stuff, drugs, alcohol, a head injury, dementia, schizophrenia, those things might help us explain what caused a patient's capacity to decline. But the presence of those things alone is not sufficient proof of capacity. Obviously, there are a lot of details about the Kowalski case that we just don't know, and we probably never will. Who said what? How did Kowalski look to the nurse when she last saw him? What assessments did the doctor perform to determine that Kowalski had the capacity to make informed decisions? Imagine for a moment, put yourself in the nurse's shoes. Once you realized that your intoxicated patient was going to leave the hospital AMA without an escort, what thoughts would have started to race through your mind? Would you have been able to just shrug your shoulders, move on to the next patient without giving the matter a second thought? Would you have been worried about being sued or getting written up by your supervisor? Would you have chased after the patient and acted against his will? Now let's be honest with ourselves here. This is where the rubber really meets the road. In your heart of hearts, we know the best thing for this patient would have been for him to stay in the ER and go to detox. His decision to leave was stupid. But people have the right to make stupid choices as long as they have mental capacity. Forget about Kowalski for a moment and think of any other patient, perhaps a 65-year-old grandpa with chest pain. Would you force a competent person to take a medication just because, in your clinical judgment, they needed it? Probably not. We might want to sometimes, and there's nothing wrong with caring about your patients. Most of us got into this business because we wanted to help other people. It's in our DNA. So without a doubt, these cases can pose some serious moral and ethical dilemmas for us, not to mention the CYA attitude that's become so pervasive in healthcare. So I don't want to sound like I'm minimizing these challenges. However, we also need to give more than lip service to the things we teach EMTs and paramedics about patient rights and autonomy. Arguably, if the patient is of sound mind, it would be equally unethical for us to force the patient to substitute our will for their own. So as we continue to compare the Brett Weiner case with the Kowalski case, what can we say? Brett was suicidal. Kowalski had made no overt or imminent threats of harm to himself or others. Brett Weiner had been hallucinating, whereas Kowalski possessed his mental and legal capacity. In Brett's case, because of the first 2 points there, involuntary care and transport was justified. The lawfulness of involuntary transport was never in question in Brett's case. It never even came up in court. Why? Because that's not what this case was about. So what was it about? How did the jury come to conclude that the attending EMT had been grossly negligent? Was it because the EMT had allowed Brett to escape and ultimately Brett died? Did the jury expect the EMT to tackle his patient in the back of the ambulance and pin him to the floor until help arrived? No. If you skim through any EMS textbook and count the number of times you find statements like, "The safety of the EMT is always the first priority," you understand that we're not trained to dogpile our patients, apply pain compliance techniques, or put aggressive people in arm bars or submission holds. Those tasks belong with our friends in law enforcement. For us to mimic what we've seen on an episode of Cops or UFC Fight Night, that would be reckless, to say the least. So what about this? Was it just the simple fact that Brett died? That seems like a logical reason to throw the book at someone. But unfortunately, that is not the case here. Like his escape, Brett's death was a result. And while damaging results are essential to any claim of gross negligence, the pivotal question for the jury was whether the EMT was in some way responsible for those damages. Had he breached his professional duty to his patient? Had he deviated from the standard of care? And if so, were those actions approximate causation of Brett's escape and death? In the jury's opinion, yes. They believed that the tragic events were set in motion when the EMT made two significant preventable errors that another EMT acting in accordance with the standard of care would not have made. First, he allegedly applied the soft restraints incorrectly. But secondly, the EMT moved from the bench seat, a position that afforded him an unobstructed view of Brett's restrained limbs, to the captain's chair, which, with Brett in the semi-Fowler's position, impeded the EMT's view of the restraints. The jury believed that if not for those actions, Brett's death arguably could have been prevented, and the standard of care was very clear that the EMS provider is to remain in a position where they can physically observe all of the restrained limbs and restraint devices at all times. Well, hey, I realize that that was a lot of information to throw at you all at once. I will put this presentation up on my website for you to review at your leisure. Just go to emsrestraint.com and click on the link that says resources. I hope you enjoy the rest of the conference. Take care and be safe.